We're continuing with chapter 16, talking about assistive devices. So, implantable cardiac defibrillators are very similar to pacemakers, and they can actually have dual roles in what they do. Cardiac defibrillators typically continues to monitor the heart and delivers shocks as needed to prevent the patient from going into sudden cardiac arrest. Typically, they have had previous history of going into sudden cardiac arrest and were brought back, or they have some rare syndromes that put them at risk for going into sudden cardiac arrest. And so they have these implantable devices. If for some reason they start having chest pain, we're treating them just like anybody else. The electricity from those implants is super low. It's not going to shock you while it shocks the patient, so you don't have to worry about that. External defibrillator vests. So this is very similar to the implanted one. However, instead of being implanted, it's worn on the outside. It's attached to a monitor that's typically hung from a belt or like a shoulder strap or a very small backpack. And it has external patches. This uses high energy shocks that go through the skin, just like our AED patches do. So don't touch the patient if it warns that it's about to deliver a shock, and it does give you a heads up that it's going to do this. If at all possible, leave the vest in place while CPR is being performed, unless it ends up interfering with compressions. Then go ahead and take it off. LVADs. LVADs, from my opinion, are very intimidating, really. So what's happening is the patient's heart is not working effective. And so this device is essentially acting as their heart. So it's temporarily boosting their heart to pump the way that it's supposed to. You may have a pulsatile type flow where it's acting just like the heart, or you can just have continuous flow. But this a device is literally their heart. So you have to be relatively careful with it. Patients with an LVAD may or may not have a normal pulse, so keep that in mind. The family, the patient should be able to tell you quite a bit about the device, since this is, in more senses than not, their lifeline. They are relatively educated on it. Unless the device has malfunctioned, just leave it alone. Don't mess with it. Contact medical control if you're unsure of what to do. Typically, they're going to know of an LVAD in the area within South Dakota. We don't have that many people. An LVAD, when somebody has it, word typically gets around pretty quickly, especially to the local hospital where they might be transported. Make sure that you transport all of their supplies in their battery pack, because if they get admitted, they're going to need those things. For cardiac arrest, you guys have already gone through the CPR class. So this is when the heart is no longer working efficiently to pump blood. Either there's an electrical failure, there's a mechanical failure, or there's both. There's absence of a carotid pulse because the heart is no longer pushing blood through. There was several deaths because CPR was not developed very well. If you look at previous videos, and you can find them on YouTube, we used to put people like in the prone position and push on their back. CPR has developed quite significantly. So people are surviving now, not at the rate we would like them to, but they are. So AEDs analyze the electrical signal from the heart, and it only shocks two different rhythms. So it will shock ventricular fibrillation And that's when the heart is just quivering. It's not actually truly contracting. And it also recognizes ventricular tachycardia. If it doesn't sense either of those rhythms, it will say no shock advised or shock not required. It kind of depends on what AED you have. Um, if that happens and you don't have a pulse, then you have some other rhythm that it's not recognizing and you need to continue CPR. They're relatively easy to use. They try to make them as foolproof as possible. Remember, the first step to operating an AED is turn it on, and then voice prompts will walk you through everything. Um, so you don't really need to know ahead of time. Advantages of AED use: they quickly deliver a shock at the appropriate energy level. You don't have to have any ALS providers on scene. You truly don't need to know what the heart rhythm is because it's going to shock the only two that you can shock to return the patient to, or hopefully return the patient to normal. There's larger pads. So this is why we don't touch the patient, because it's more efficient, but there's still a risk of you getting shocked as well. So all patients should have an AED put on them when they're in cardiac arrest. Again, if the patient is asystole, there's no electrical activity. Pulseless electrical activity is another state of cardiac arrest. So the electrical activity is there in the heart. It is an organized rhythm that should be producing a contraction, but for some reason the heart muscle is either damaged or just not responding, and it's not going to shock that either. If you have any sort of organized rhythm, you're not going to have an AED that's going to recommend a shock. That's why we don't touch the patient while it's analyzing, because we can actually cause what looks like an organized rhythm, and it may not shock something that it really needs to shock. Early defibrillation helps people survive out of hospital cardiac arrest. Most oftentimes when somebody goes into sudden cardiac arrest, the rhythm that puts them there is VFib, ventricular fibrillation. That is something that the AED recognizes, shocks, and it can potentially terminate that rhythm and allow the heart to resume its normal function. So certainly we want to use these as quickly as possible. We don't delay CPR for that AED. Typically there's going to be more than one person that can get the AED. And somebody that's experiencing chest pain, you should have the AED available and ready to go just in case you need it. When you have somebody that you have used an AED on and you manage to get them back, you want to continue ventilation. You want to try and get ALS to rendezvous with you, because you need to ensure a blood pressure that's greater than 90, and it's hard to do that without fluids and medication. You want to try and maintain glucose levels. Oftentimes patients will remain unconscious after CPR, and so it's really hard for you to administer oral glucose. So ALS is needed for that, but rapid transport definitely needs to happen. You want to continue ventilation at 12 breaths per minute. Maintain your oxygen saturation between that 95 and 99. We have already talked about some AED CPR stuff, so I'm just going to go ahead and go on to the next one. Maintaining your AED. So you need to make sure that you follow the maintenance guidelines. Every manufacturer does have recommendations for how to fix that. So you should be familiar with how that works. The three most common failures of the AED is failure of the machine to shock fine VFib. Fine VFib can look an awful lot like asystole, and so it may or may not shock it. If you apply the AED to a patient who's moving, squirming, or being transported, typically if they're awake and doing their thing, even if they have chest pain, even if they have a dysrhythmia, we're not going to put the patches on them. Just in case some places do have that in their protocol, but typically you don't need to do that. And you should not turn off the AED before it finishes its analysis or the shock is completely complete. Make sure that you let it completely roll out. You shouldn't actually turn off the AED unless you terminate efforts. You need to make sure that you actually put the AED on the patient. Sometimes that can be a little iffy. Make sure that you push the analyze or shock buttons when the machine advises you to. Typically, the analyzing portion, it does automatically now. The shock, you will actually have to press the button. Make sure that you press the shock button and not the power button. You want to make sure that you know you have battery in the device. A lot of them have sealed batteries, so you just have to check them. But that's part of your equipment's check at the beginning of each of your shifts. You want to report any failures to the manufacturer and to the FDA. There should be a protocol for how you do that. And then make sure that you let your supervisors and stuff know as well, because you need to take that out of service. Medical direction should approve a written protocol for AED use. You should already have that in place and you should know what it is. You should always submit for quality improvement that reviews every incident that an AED is actually used to see if there's a chance to provide, irregardless of what the patient's outcome was. Quality improvement, they may end up bringing you in to talk about your use and how it went, things that you could have done better. The review for quality improvement is going to look on the speed of defibrillation. So from the time that you arrived to the time that you actually applied the AED and that first shock, was that in a timely manner? Shock should be delivered within 1 minute of your arrival on the call. So get in there, no pulse, start CPR, apply the AED. It should be very, very, very quick. And you should do continuing education and skill competency checklists to make sure that you know how to operate your AED appropriate well before you end up getting a call to do that. Emergency care for cardiac arrest. You are the safety officer on this, so you want to make sure that nobody's touching the patient when you shock, when you're analyzing. We're not defibrillating patients in pooled water, so remember, you can have them in a small puddle or on snow, but if they're in a large puddle of water, move them quickly, dry off the chest. It doesn't need to be completely dry. Don't defibrillate patients that are touching metal, that other people are touching. Electricity travels through metal. Carefully remove patches from the chest with a dry towel because those patches can actually ignite and catch fire. You want to shave that hairy chest or wax it with the pads if you need to make sure that you have a good connection. Here is a flow of what you should do and what steps you should take depending on what's going on. This should be in your book as well. So chest compressions first, apply the protocol. After the protocol is completed, you may have a pulse regained. No pulse regained with no shock advised. No pulse with a shock advised. Wait for ALS, continue shocks and CPR. Make sure that you do call ALS because we have medications that you don't have. So keep going. If an AED is available,